Hello, everybody, and thank you for joining us again for another one of our fabulous MAG seminars, educational seminars with our specialists. Today we have the very lovely Dr. Yu-Tang Shen, who is one of our newer specialists on the panel, and he is a psychiatrist with a specialty in old age psychiatry. So right up my alley. But he also has experience and expertise in psychotherapy, some experience with neuropsychology and people with intellectual disabilities, and of course, mood and anxiety disorders, and the wonderful subject for today's talk, post-traumatic stress disorder. May I ask that you all please remain on mute during this session. There will be a time for questions at the end. I ask you to be on mute so that noise from your home or office doesn't interrupt the recording or compromise everyone else's ability to listen and follow the talk. The recording of this will be sent to you hopefully by today, but it could be tomorrow. And of course, it will be put up onto our YouTube channel where you can enjoy that at any time. You can access that via Googling Medicolegal Assessments Group on YouTube, and we will pop up. Or in your MAG Connect or MAG Cowercon, login, you can click on the menu bar on educational resources and be taken straight to our videos. Without further ado, I will hand over to you, Dr. Shen. Thank you so much.
Thanks for that, Michelle. So today's talk is on post-traumatic stress disorder, or PTSD. And so it's a pretty prevalent disorder, and it's quite commonly found in many different areas in medicine, and sometimes arising because of medical treatment, and also in the medical legal context. So just a little bit about the talk that I'll be giving today. I'll be covering the process of developing PTSD, going through the diagnosis of PTSD, as well as the diagnostic criteria and the symptoms people get, any co-occurring conditions, as well as some of the assessment tools and screening tools, and also treatment considerations today. So in terms of the process of developing PTSD, in a way, it's almost captured by criterion A of the diagnosis. It is about exposure to a traumatic events, or in some cases, repeated exposure to traumatic events. And often that happens when people are exposed to something that's quite negative and produces a lot of intense negative feelings, and have people feeling like they're trapped in that situation. And when that happens, there's lots of changes that occurs in the body. There's changes that occurs physiologically, so we can activate the sympathetic nervous system, and people can get quite physiologically aroused, where they have heightened heart rate or blood pressure or breathing rate. And at the same time, it imprints that experience or exposure to the incident into people's brains. So it's really seared into their brains, where they get quite easily afraid and avoidant of the incident. And really, it's an evolutionary tool to make us, to raise our awareness of the dangers to our lives, so we can make sure to avoid it in the future. So it is pretty prevalent. It's about 10 to 11% lifetime prevalence in Australia, around the same elsewhere as well, depending on other stresses in other countries. And the diagnosis that we tend to use in Australia is based on the DSM-5 criteria, and so that includes a few different criteria. So the first one is an exposure to a traumatic event, as well as intrusive symptoms, avoidant behaviors, and negative alterations to cognition or mood, or thoughts and feelings, and alterations to arousal and reactivity. And then there's the duration criteria. It has to be more than a month. It has to involve significant associated distress or impairment as a result of the symptoms. And it has to be because of these symptoms and not because of other reasons. So I'll just go into the criterion A, which is the exposure to a traumatic incident. And the traumatic incident has to involve actual or threatened death, serious injury, or sexual violence. And it can be experienced in a few different ways. It can be experienced either directly, where those incidents are directly targeting the person. It can also be from witnessing it occurring to other people. It can also be from learning vicariously of those incidents occurring to someone else, usually a close friend or a close relative. And it can also occur in the course of work where there's repeated or recurrent exposure in the line of work that people do. And so from a more practical perspective, that occurs a lot in people involved in car accidents. And car accidents where they're the injured party or there's threats of injury. And also where they could be witnessing a car accident occurring to other people, or if they are the subject to a workplace accident and receive serious injury or witness it in other people. It can also be from occupational exposure. You see it quite frequently in frontline police officers, as well as firefighters and also health professionals as well. And it doesn't have to be direct exposure. Again, it can also be from repeated exposure to graphic details of difficult scenarios that people have had to go through as part of their work. One important thing to note is usually bullying doesn't meet the criterion A, especially in the workplace, unless that's associated with a credible threat to serious harm or sexual violence. And that's probably an important thing to note, because a lot of time, even though people develop these PTSD type symptoms associated with bullying in the workplace, especially, if it doesn't meet criterion A in terms of the threat level, then according to the DSM, it doesn't meet the diagnostic criteria for post-traumatic stress disorder. And in which case it'll cascade down to the next diagnostic criteria or diagnostic syndrome that they might meet, like another anxiety disorder or a mood disorder, for example. Another thing to note is because one of the threshold is threatening death, that involves a degree of subjective experience of the person. So even if they haven't experienced a direct injury as a result, for example, being involved in a car accident, they can still cause PTSD if they, at the time of the accident, thought that they were at risk of dying or having serious injury. There's a bit of a gray area where a lot of it is subjective experience, and you do have to rely a lot on the person being assessed in terms of their subjective experience of threat perception. So that's something to note with that. Now, criterion B is about the re-experiencing symptoms. And so re-experiencing symptoms are more about the memories of the accident coming back again. And the memories can be of the accident. Sometimes it's about what happened after the incident or accident. Sometimes it's about associated responses from either employers or friends or colleagues or what have you. The memories can sometimes occur spontaneously, and sometimes they can be triggered by other reminders of those incidents. And in order to meet the criteria, it has to be recurrent and distressing. The other possible criterion is recurrent dreams or nightmares about the accident again, or about themes related to the incident. It can also be re-experiences dissociative flashbacks. So these are when people dissociate. So they're kind of detached from reality in the present, and they feel as if they're back there in time again, re-experiencing what happened, or snippets or fragments of what happened there. And again, often quite distressing for them. And the triggers are anything either internal or external that remind people of the incident. Usually certain themes that are linked to the incident, and it can lead to psychological symptoms of distress or physiological symptoms of distress. And some of the common triggers that can be found in the personal injury context can be from pain from a physical injury people have had, or from the disability, especially from the physical injury as well, giving them a significant contrast to how their life was pre-injury. It can be from medical assessment, particularly independent medical assessment, where they feel like each time they have to relive the incident when they go through it again. And that can be associated with the heightened level of arousal, anxiety, or distress in the lead up to, during, and also after the independent medical examination. And other parts of the process that happens in a claim can also raise the distress levels, because it can trigger off having to think again about those memories and bring them back again. Criterion C is about avoidance, and avoidance can be either from internal reminders or external reminders. So in terms of internal reminders, people tend to try and avoid thinking about it or feeling about it, or even trying to distance themselves from memories. It can be quite effortful, or in some cases it can be automatic. And avoidance of external reminders, so those are about things that we can see or hear or feel. And often those could be people associated with the incident, or places, or even talking to friends about the incident, or being in situations that remind people about that incident. In car accidents, for example, people typically try and avoid the site of the accident, or try and avoid going back to the workplace. That evokes a lot of memories of the accident. In terms of criterion D, so these are alterations of cognitions or thoughts and feelings. That can include dissociative amnesia, where the brain shuts down automatically any memories associated with the incident as a way of protecting people from having to relive the incident again. It can be from negative beliefs of how you feel about yourself or other people. For example, that you're bad and that's why the incident happened to you, or other people are bad and can't be trusted. And that can lead to difficulties trusting other people. It can lead to people blaming themselves or blaming other people. And to be clear, this has to be in a fairly disproportionate and almost unfair way of blaming yourself, for example, where if they hadn't driven down this lane, for example, then the accident wouldn't have happened, or if they hadn't done this, then it wouldn't have happened. Persistent negative emotional states can occur. So that's constant feelings of fear, horror, anger, guilt, or shame. Diminished interest, where they are no longer engaged in pursuing the usual hobbies they have had, or detached from other people, for example, from their family or friends, where they might not be as motivated to engage socially with them. People might also struggle to experience positive emotions and feel quite emotionally shut off, even if they are doing the things that they usually enjoy doing. Now, some of these symptoms do overlap with symptoms of depression. For example, the persistent negative emotional states, or the self-blame and the diminished interest and detachment from others. So sometimes there is a bit of an overlap there. In terms of criterion E, so that's alterations in reactivity and arousal. So that includes things like having an irritable behavior or outburst, being more angry than usual and acting out because of that. Self-destructive behaviors such as reckless driving, unsafe sex, impulsive drug use or alcohol use, suicidal or self-harming behaviors. Hypervigilance, so being on edge in case something similar happens again. You see this in people who've had car accidents, being very, very anxious, always looking in the mirror when they're in the car, if they're driving, always looking out on the roads just in case that a car accident happens again, or, in a cafe, watching the exits all the time in case someone bad comes back in after an assault. Some people get exaggerated startle response where they might get startled easier, but also with a much more disproportionate startle reaction. Often people struggle with concentration difficulties, and that can have impact on memory, short-term memory as well. And often they have sleep disturbances, sometimes as a result of nightmares and sometimes irrespective of nightmares. So those are the symptoms of PTSD. Now, some people also get dissociative symptoms associated with PTSD, and there's two types of dissociative symptoms. Dissociative symptoms are when people detach a bit from reality in a way to protect themselves from feeling too much in reality. So depersonalization are when people feel like they're no longer embodied in themselves. So they might feel like they have an out-of-body experience or they don't feel like themselves. Derealization is where they feel a bit disconnected from reality, where they feel like things around them are not real or things are dreamlike or they're in a dreamlike state, for example. And sometimes these symptoms specifically themselves cause problems with people functioning. It's important to also consider differentials and also comorbid conditions. So differentials are when you have to try and decide if it's PTSD or something else. And comorbid or co-occurring conditions are when other conditions occur at the same time as PTSD. In psychiatry, it often happens where there's multiple psychiatric diagnoses co-occur a lot of the time. And part of that is because there's a lot of different types of symptoms that come up. And in psychiatry, a lot of time when we diagnose, it's based on symptom clusters. And so if there's a lot of different symptoms, then you use more labels to capture all of the symptom clusters. Quite a lot of time there's generalized anxiety, often when people are anxiously worrying too much about things that might happen or catastrophize. One thing to try and differentiate a generalized anxiety is the themes of those worries. If the worries are more specific to the PTSD or the themes of the incident, then probably would be subsumed under the PTSD diagnosis, unless the anxious worry is more generalized, where people are worrying about everything else that are not specific to the PTSD. Same with panic attacks. If panic attacks are occurring when people are having triggers for the PTSD, it would be more subsumed under the diagnosis of PTSD, whereas if they have panic attacks irrespective of any PTSD related triggers, they might have an independent panic disorder. Major depressive disorder is a common co-occurring or comorbid condition. Again, sometimes it can be subsumed under the PTSD, especially because there's a lot of overlap between the symptoms, particularly with the alterations of cognitions and mood, as well as alterations in reactivity and arousal. So there's an overlap with some symptoms like sleep disturbance or concentration or diminished interest or detachment or difficulties experiencing positive emotions. However, there are some depressive symptoms that are independent of it. So, for example, motivation or energy, as well as suicidal thoughts, might be some of them. Or if there's quite a significant amount of depressive symptoms or depressive mood that are not associated with the triggers of the PTSD, you might want to consider having it as a co-occurring condition. But if a lot of the depressive symptoms are more associated with the themes of the PTSD or the themes of the incident related to the PTSD, that might be something that could be subsumed under the PTSD diagnostic label instead of a separate major depressive disorder diagnosis. Alcohol use disorder is fairly common, and so that's something to screen for as well as dissociation. Obviously, that is a subtype of PTSD. And also another co-occurring thing is pain, usually in where there's significant physical injury, but certainly that can be a trigger for PTSD symptoms coming up again. In terms of assessment, so usually people having a psychiatric assessment have a psychiatric diagnosis from an interview. with a psychiatrist. Sometimes, though, there are some people go through validated diagnostic interviews or use validated screening tools. One of the gold standard diagnostic tool is the CAPS-5, or the Clinician Administered PTSD Scale, or DSM-5. So it's DSM-5 compatible, goes through all of the diagnostic criteria, and also assesses the severity of each of the criteria, as well as the impact or distress associated with it. It can be used for monitoring treatment response. It can also be used to track progress over time, in other words. Typically takes about 30 minutes, so over time it's not used so commonly, and it is not mandatory to use in order to diagnose PTSD. There's a few other screening tools that can be used quite commonly. So one of the ones specific to PTSD is called the PTSD checklist, for DSM-5, or PCL-5 for short. And so it's fairly compatible with DSM. So it asks most of all of the symptoms of PTSD, and it's a self-reported tool. And it can be used to screen for PTSD. It can also be used to give a provisional diagnosis of PTSD. Although it'll be up to some of the people using it as to whether or not it gets accepted as a diagnostic instrument. It can also be helpful in tracking progress in terms of treatment progress over time. Another screening tool that is specific to PTSD is called the Impact of Event Scale Revised, or IESR Revised. So that has 3 subscales. So it tracks things like arousal symptoms or avoidance symptoms. It doesn't tend to, it's a bit less DSM-5 compatible. It's a bit older than the PCL-5, but I've seen it used in some instances, so some people still use that. And then there's a couple of other screening tools. So one of them is the Tesla Psychological Distress Scale. So that is a fairly user-friendly screening tool, fairly fast to use, just to screen people in terms of their level of distress at a given time. It's not specific for PTSD. Another commonly used scale is the Depression, Anxiety, and Stress Scale, and that can convert into a few different subscales for depression, anxiety, and stress. Can be used for tracking people's distress, because a lot of those symptoms can be of PTSD can be captured by the DAS-21 scale still, even though it's not specific for PTSD. Other considerations for the development of PTSD. So there are risk factors. So a lot of times having a pre-existing history of mental disorder can predispose people to getting PTSD. And it's a bit of a double-edged sword, because people are more predisposed to getting PTSD, but also it can be, in a way, used against them in terms of trying to differentiate causality or contribution from pre-existing psychiatric disorders. People from poorer social backgrounds, or from other cultures, or lower socioeconomic backgrounds tend to get higher rates of having PTSD. And sometimes there's a genetic vulnerability as well. Stresses following the traumatic incident play a huge role in determining if someone develops PTSD or not. So the severity of the physiological response in relation to the traumatic incident, the level of social support that they have, the financial, if there's any associated financial stress, if there's any associated physical disability or pain, or even brain injury. So all of those will contribute as well to the risk of developing PTSD. So in terms of treatment, so this is roughly based on the treatment guidelines from Phoenix, Australia, which is our Australian guidelines. They do recommend specific types of therapy, such as cognitive processing therapy, trauma-focused cognitive therapy, eye movement desensitization and reprocessing therapy and prolonged exposure. All of these are more related to accessing the trauma incident, how it's been imprinted into the brain, and finding ways to unravel the stuckness that people are at, or trying to process those experiences. So those psychological therapy is still first-line treatment for PTSD. There's also other types of psychological therapies that can be used, sometimes things like supportive therapy as well, for example. Second line, if people aren't responding well to psychological therapy, then people can consider SSRI, antidepressants like SSRIs. Examples include paroxetine, sertraline, escitalopram, and then venlafaxine, which is an SNRI, if the SSRI alone is not enough. In terms of other symptomatic treatments, sometimes sedatives are used for sleep. Obviously, there's the issues regarding long-term use or sedatives with respect to dependence tolerance and also other side effects. Sometimes we do use propranolol specifically for panic attacks and anger attacks rather than for PTSD specifically. Nightmares, there's medication options for that. So they tend to include clonidine and prazosin and also topiramate, low-dose topiramate. In terms of response rate, so response rate for psychological therapy is probably around the 20 to 50% mark, and medication is probably around the 20% to 30% mark. Sometimes people improve spontaneously without treatment, probably around 20%. And each time you add on or escalate treatment, it might improve their chances, although that's pretty individual, depends on other contextual factors and how treatment resistant their condition is. There's a few novel treatments that's come out. So TMS, there's emerging evidence for the use of repetitive transcranial magnetic stimulation. At the moment, TMS is only Medicare subsidized for depression or treatment-resistant depression, but there's more and more evidence for its use in other conditions like PTSD. The other thing is MDMA-assisted psychotherapy. So that's been something that's been downscheduled by the TGA recently, and some psychiatrists have started to use MDMA-assisted therapy. It's not easily accessible and pretty expensive still, and arguably some people might still call it still in the experimental phase. Roughly, the response rate is probably about 50 to 60%. And for the ones who do respond, they tend to keep their response for up to 2 years, as far as we know at this stage. So that's a growing option. Obviously, it depends on access and funding. The other thing to remember is also to treat any co-occurring or comorbid conditions like depression, although depression can be captured under the same psychological therapy and antidepressants that we use for PTSD. And also screening and addressing any alcohol use disorder or other substance use disorders as well. Pain management is also fairly important, if possible, pain management to be optimized as much as possible. In terms of treatment considerations, a lot of times there's a lot of different factors that are not medication related when you try and think about what fits people the best in terms of what access or what treatments to use. Part of it depends on training of the person assessing them, or training of or skill set of the person treating them. And a more practical factor is the access to services and what services are actually around that's accessible. For example, TMS is not available quite easily in the regional or rural areas. MDMA-assisted therapy is not really feasible for most people. Also, if there's any financial constraints, particularly with ongoing regular therapy or with some of the medications that can be quite expensive, for things like TMS or MDMA assisted therapy. Other considerations include people's personal attitudes to treatment. Some people prefer to avoid medications, in which case sometimes it can be quite detrimental to try and force or coerce people to have medications against their will, and often doesn't have positive outcomes. Conversely, some people prefer medications over psychological therapy, in which case it might be better to go with their preference instead, particularly because sometimes it can be quite a difficult experience for people to have to go through therapy, because they have to re-experience the traumatic incident, and they might not have they might not be at the right space to be going through those traumatic incidents at that time. In order to give therapy a good go, ideally, it'd be good to engage in therapy on a regular basis, say once a week or once every 2 weeks for a good 6 to 12 months. Again, everyone is quite individual in terms of the pace that they need or how fast they can go through it, and also the motivation with what kind or what part of the PTSD they can address at any time. And also with medications, often a good response would require people to be at an adequate dose for at least 6 weeks to have good response. Part of that is counterbalanced by side effects. So a lot of these medications do cause a lot of side effects, things like headache, blurred vision, dizziness, bowel changes, emotional numbing, things like that. And that can limit the degree of willingness people might want to use medications. Also, the other things are paying attention to people's psychosocial functioning, making sure that that's also treated or supported as much as possible, such as their self-care, their interpersonal functioning, social functioning, how they get out and about, and also their work commitments as well, trying to help support them. In terms of a few things specific to the medico-legal aspect, so one of them's the ongoing triggers. So having engaged with the claims process can be quite triggering in itself, especially if people have to attend multiple medical examinations or have a conflict over liability and things like that with the insurance. It can also obviously have interference with their treatment because of it, if there's any issues or conflict over funding of treatment, for example, or funding of specific treatment. Also going through the independent medical examinations sometimes can make their symptoms get worse in the lead up to it, and also following the examination. Some people do worry about the possible perverse incentive in symptom exaggeration. So the way the system is built up is people do tend to get more compensation, for example, with the more symptom severity or functional severity, functional impairment severity. And so sometimes they can be an incentive to be more sick. And so those are the things to have to kind of grapple with. Another thing, not necessarily directly related to the severity of symptoms sometimes. So a lot of the time, the function is more related to psychosocial support that people have. They tend to be probably more functioning if they have much more psychosocial strengths, like intact family, or very supportive, very flexible work conditions, things like that. And conversely, if they have very poor social support, they might struggle with their function more. So I suppose the takeaway is, in terms of diagnosis, being sure to screen for the diagnosis. You might want to consider using the screening tools like or the Kessler Psychological Distress Scale, or perhaps even using the PCL-5 checklist. And part of that is also assessing for co-occurring or comorbid condition like depression, suicidality, alcohol use disorder, for example. And also in terms of treatment, making sure that people do have access to psychological treatment or offer that if possible, and considering medication in discussion with the person, and considering referring early if there's a lack of progress after an adequate amount of psychological therapy or medication treatment, just in case, they might benefit from an escalation of treatment earlier on. Yes, so that was the end of my talk.
Dr. Shen, that was fascinating. It was really, really good. People, does anyone have a question that they would like to ask? You can unmute yourself and jump in, or you can type your question in the chat. Yes, here we go.
I would like to ask a question about medication, if I may.
Yeah, absolutely.
Yeah, so you mentioned that some people don't want to take medication. And it seems to me when you have people who don't want to take medication, they often have very strong or firm opinions about taking medication. How reasonable or unreasonable is it to decline medication? And is there anything we can do or say that might change people's views on medication?
That's a good question. I don't have a perfect answer or one size fit all answer. Everyone's a bit different with the reasons that they have. And sometimes it can be quite personal. Sometimes it's more ideological. So sometimes it's more about seeing other friends or other family members and how they've responded to medication, usually quite adversely. And so they're fearful of being on it. Other times it's seeing the consequences of it. For example, a lot of police officers don't tend to because they see, people who they've had to pick up who have adverse reactions or what they attribute to adverse reactions to medications. Part of it would depend on their motivations and goals and how they want to get there, and talking through with them. These are the available options that we have. If you've tried psychological therapy, maybe there's a bit of benefit, maybe not enough. You're still struggling. If your goals are to improve further, these are the other available options. If you're afraid of side effects, we can certainly start at a very, very low dose and go up very slowly. And you have the option of stopping at any point that you want. Other times it could be them speaking to other peers or peer workers, if possible, or other people who are on medication who have had a positive experience without too much adverse reactions. Sometimes that can be enough to sway their minds. But sometimes that's not enough and nothing may sway them, or they're not ready at that time. They might change their mind later on in the future, and some people do. And in part, it's a bit of a watchful waiting and offering that to them if they're ready. I suppose an alternative might be having a look at other non-medication options like TMS. TMS is not related to medication. Sometimes you can talk people around into that as well. Yeah.
Thank you. Teresa, I saw that you unmuted yourself. Do you have a question?
Yes, I have a question, Dr. Shen. You mentioned about the assessment tools, right? There's a few tools that you can use. As a lawyer, I just do not know if, let's say, one doctor applied this the PDS scale for DSM-5, and other doctor use another tools. Does it have any impact on the WPI as a result of that?
No, so the WPI is probably assessed quite separately to the tools. Remember the tools capture symptoms, but it doesn't capture the psychosocial functioning. And the WPI is more related to the psychosocial functioning. That relates to one of the points was sometimes the severity of these symptoms doesn't directly correlate with the severity of the functional impairment. But what would be helpful with the using those screening tools is at least you can track the symptoms over time. It's more helpful if they use the same set of screening tools because different screening tools will have different psychometric properties, and it's a bit hard to actually have an equivalence between different screening tools.
I see. In relation to which technique do you use most often? Which
Sorry.
tool do you use?
Hmm.
There's a 1, 2, 3, 4, 5.
Yeah.
There's the PTSD scale for the DSM-5. The scale is most tools is
Useful.
more
Yeah.
useful and more popular, or which so we want to see, let's say if one report will use this scale and the other report use the other scale, will have an impact on the outcome.
Yeah, got it. I think if the gold standard would actually be the CAPS-5, the clinician administered one, but that would be through a structured interview with someone asking questions and then making decisions of their own. So it's not a self-rated scale, but that would probably hold more weight than the others. And then after that, in terms of the self-reported screening tools, of those ones that I've mentioned, PCL5 is probably the one that tends to be used the most and probably the better one to use. But the one that tends to be used the most is the DAS21 or the K10, just because they're easier for more people to access, and a bit more generic or a bit less specific. So it tends to capture more symptoms.
I see. Thank you.
Thank you, Teresa. Does anyone else have any questions? Dr. Shen, I have a question from somebody who was unable to attend today. And it's actually touched on something that Teresa raised just then. And their question was, with the diagnostic tools, some are easier to apply, as you've commented on the DSM, whereas others take a longer period of time. The average IME assessment is roughly 1 hour of time. How can a specialist provide an IME and an assessment in an average 1 hour that takes into account the use of a diagnostic tool, or must they not do so given the time constraint?
They never need to do so, irrespective of IME or not, as long as we are satisfied that the person being assessed meets the DSM-5 criteria or whichever diagnostic classification you're using for that given diagnosis. But it's just that we need to prove ourselves usually, and one way is to use these structured tools. They're probably not meant necessarily to be used in the medical legal setting. They're more used in the research setting, but they're gold standard assessment. We don't tend to rely a lot on scales as psychiatrists, although some of us do, but it's not a central component of our assessments. That's probably more the domain of psychologists, and because that's more about how their trainings come from, whereas our trainings come from more the diagnostic interview as our tool of sorts. Some of us do use it. A lot of times when you do conduct our interview, a lot of it will satisfy DSM-5, and it probably would satisfy CAPS-5, but probably to a less specific degree, because CAPS-5 rates down the severity of each of the symptoms, whereas for DSM-5, we just need to be sure that they exist, and they exist to a sufficient standard of impairment or distress.
Cool. I've got one more question, again, from someone who wasn't able to attend today. This person says, I work with a lot of first responders and that sort of people, brackets, police, ambulance services, etc. There's a lot of talk currently about the fact that people who have a PTSD diagnosis can in fact be returned to work and have great outcomes, but it must be in the non-triggered environment. Are you aware of this change in shift?
Yeah. I mean, that would be the more sensible one. Part of it is because of the triggers. And so if they return back to the place where the incident happened, or have to do work or roll around the trigger or the incident, it can trigger off their symptoms and make it worse or come back again. So it's a bit tricky sometimes. It really depends on the context. Also depends on how well treated they are, how well they're able to process it. And some triggers, sometimes they can process better than other triggers as well. Also depends on other motivating factors. A lot of it is, people's work is wrapped up with a sense of identity and sense of pride in themselves as well. If they have young kids, a lot of the time it's also to be a good role model for the kids and also financially for their family. So all of those other factors sometimes get into, when they feel ready or when they feel like they need to return to work.
Lovely. Look, thank you so much, Dr. Shen, for another fascinating seminar for our many clients and people who view these. Thank you, everybody, for joining us today. Once again, the recording will come to you possibly by the end of today, but if not tomorrow, along with the slides. And you can watch this up on our YouTube channel or through your MagCowerCon login. I thank you so much, Dr. Yu-Tang Shen, for sharing your time and your expertise with us today. Everyone, have a great rest of the day.
Thanks. Bye.
Thank you.